Well, Reem, طيب no problem. Best song. Okay. Afternoon. Hello from Iraq. I'm Dr. Hussain Al-Huwaizi. Okay. I'm very happy to be with you all. My lecture is going to be about root canal irrigation, new strategies. New strategies for better cleaning and disinfection. I'm Professor Hussain Al-Huwaizi. I'm the chairman of the scientific committee in the Iraqi Dental Association, the coordinator of the Iraqi Endodontic Society, and a professor in the College of Dentistry. I'm a member in many endodontic societies. First of all, before everything, I hope that you are very safe from the COVID-19 outbreak. We're trying our best to share with you our knowledge about our knowledge. No, but really all this work will not be a lot, considering the work and the our medical staff, who are really they are the heroes of the day. They are risking their lives for us. So I really urge you to stay at home, and we will try our best to send you lectures as much as possible. Going back to our lecture, any disease caused by infection should be able to regress after removal of its causative irritant. That means any irritation, anything that happens in the root canal, if we remove it, healing will happen. And the most irritating thing is bacteria. So we have to remove this bacteria in order for healing to occur. Now, the triangles of root canal treatment, previously we used to think of the diagnosis, the cleaning and shaping, obturating, but really we didn't concentrate much about irrigation. Irrigation is very important because we clean the root canal from any debris that has been made by instrumentation and obturate in a clean environment. We can see here that that 30 to 50% of the root canal walls are uninstrumented, no matter what we do of instrumentation, whether rotary or anything else. Because as we can see, this is one of my cases, that we've got isthmus in the coronal area, middle, and the apical area. If I don't use irrigation and vigorous irrigation with ultrasonics, maybe, I will not clean this difficult anatomy. We can see here a tooth. This is the buccal view. It's a very narrow distal canal. It seems to be easy to instrument with rotary, but when I take a mesial view, I can see that it is a very elongated cross-section root canal. It will be very difficult to instrument and clean this area just by instrumentation and routine irrigation. I need something else of irrigation to clean this anatomy. This is one of my cases. The patient came with a lot of bone loss. This tooth, the lower central, is necrotic, and it is the cause of this problem. And we know that in the lower central, we may have two canals or an elliptical one canal. So after vigorous instrumentation and irrigation with ultrasonics and then obturation, I always use thermophil obturation. You can see that bone healing has happened after 4 years. We need to follow up our cases. So root canal irrigation needs irrigant fluid, delivery devices, and agitation devices. I have to agitate, move about the irrigant fluid in order to the fluid to act. We'll talk now about the irrigation fluids. It has the physical mode of action, biological, and chemical. What do we mean by biological? In order to do instrumentation and irrigation, I need to concentrate about the apical area of the root canal. This is the most important area because it has so many variations: lateral canals, laterally positioned apex, maybe an isthmus here. There's a lot of variation here. If I can clean, irrigate, dry, and obturate very well this area, there will be healing in the periapical lesion, in the periapical area. This is one of the cases. A patient came to me from a very well-known surgeon. He finished up his surgical treatment, and he found that there are 5 teeth non-vital. Now, in order for this lesion to heal, the 5 teeth, they have to be endodontically treated because they are the source of bacteria inside the root canal. So after doing root canal treatment and vigorous ultrasonic irrigation with sodium hypochlorite and EDTA, I saw that this huge lesion, it receded after 18 months, and you can see signs of healing here. It needs around about another year or a year and a half for complete healing. So the size of the lesion doesn't really matter much if for healing, if I can do my treatment well. This is another case. You can see the big lesion here, and the canal is very wide. So here we do the instrumentation and a lot of irrigation to give a very good environment, then obturation with a slight puff of sealer outside, indicating that this obturation is very good. And I think this will be a very good environment for healing, and you can see the healing. So lateral canals are really present in the apical region in the most areas. The apical, 17%, and then it decreases as we go coronally. So we have to concentrate on this spot in this area. You can see that we've got lateral canals here, double lateral canals here. So you may see all sorts of things. The physical mode of action of the irrigant, we remove the debris. It has to have a low surface tension so that it can clean and wash the canal, the wall. It has to have a lubricant action and a slight bleaching action, so that this picture hopefully will be like this, totally clean, so that I can obturate. The chemical mode, here we have to dissolve all organic and necrotic tissue that's still there in the root canal. And we have to kill all the bacteria that are present on the smear layer and embedded in the smear layer in the cracks. Types of irrigant fluids, we've got so many. But really what stands out up till now, they are sodium hypochlorite and EDTA. In 1859, they started thinking about irrigation. They used a deodorizing agent. Then in 1894, they used calcium and sodium salts. In 1941, sodium hypochlorite with hydrogen peroxide. And in 1957, they used EDTA. So irrigation is very well known for its importance in endodontic treatment. You can't do a good endodontic treatment without a good irrigation. Now, the most important up till now is sodium hypochlorite. It is effective to kill bacteria. It removes or dissolves organic tissue. It has a good lubricant action. I think you sensed the lubrication when you use sodium hypochlorite, and you see it's very lubricant and is an oxidizing agent. Disadvantages, it is toxic. We have to bear in mind that it is toxic. It shouldn't go to the periapical region. It doesn't remove the smear layer, and it causes discoloration. We may use a concentration from 0.5% to 5.25%. I personally like to be in the middle. 2.5% would be nice. This is a case. As you can see, this file didn't enter much. I used the sodium hypochlorite with its very good lubricant action, and I managed to go to the apical region, clean, irrigate, instrument, irrigate vigorously with ultrasonics, then obturate, and you can see the septum healing here and a very good periapical healing. Now, there are factors that affect the activity of sodium hypochlorite. For example, concentration. You decrease the concentration, you decrease the toxicity, but at the same time, you decrease antibacterial and tissue dissolving action. That's why I told you I really like 2.5%, which is in the middle of everything. If I increase the contact time with bacteria with sodium hypochlorite, I increase the reduction of bacteria. That's why when you irrigate, you have to place the irrigant sodium hypochlorite for, let's say, a minute or 2 minutes for it to act. Temperature, if we increase the temperature of sodium hypochlorite, you increase the tissue dissolving action. For example, 1% sodium hypochlorite at 45 degrees Celsius equals the action of 5.25% at 20 degrees. So you can imagine the effect of the temperature. Normal saline, we may use it, but it has only a mechanical flushing action. H2O2 is wonderful. It makes bubbling action, liberates oxygen to kill bacteria, and it has a very good antibacterial action. Chlorhexidine is a powerful antiseptic agent. It's 2%. You can see that in endodontics, we use 2%. In perio, for a mouth rinsing, we use 0.12%. So our concentration is much higher. It has no tissue dissolving action, and it can be mixed with many materials to make one irrigant. Now, this is important. I want to use one irrigant instead of many irrigants, as the Q-mix, which is chlorhexidine, EDTA, and a surfactant. This surfactant increases the penetration in the dentinal tubules so that my irrigant enters more into the dentinal tubules to kill the bacteria and make the area clean. Of course, EDTA, it dissolves inorganic tissue. Now we will start with the inorganic tissue. EDTA is the best. We may use it alternatively with the NaOCl, and the best concentration is 17% for 1 minute. And it's important to leave it for 1 minute so that it can work and dissolve the inorganic tissue. We may use citric acid with a concentration of 1 to 50. It removes smear layer. And we've got, again, combinations like the MTAD, which is an antibiotic, citric acid, and a detergent. This solution has a chelating action and antimicrobial at the same time. It's important in such cases that I use my EDTA because I have got a lot sclerotic canal here. I can't see it. So with the EDTA and sodium hypochlorite, I started with my small files and glide. Glide is EDTA with urea peroxide, gel, and open the canal to obturate it. Now, just placing the irrigant material alone will not do the job. It will not clean efficiently. I need something to agitate it. First of all, we've got the manual. The simplest is bringing a gutta percha cone, irrigate the canal, and placing the cone and make it go up and down motion to agitate. Or we may use brushes or do nothing, just the routine syringe irrigation. Or we may go to the machine assisted. For example, ultrasonics, sonic, continuous irrigation with rotary, like, for example, the SAF, pressure alternating, lasers, and mechanical brushing. Ultrasonics are mostly used. We've got many tips that are long-shanked, and they are placed inside the root canal that has a lot of irrigant and will agitate the irrigant. Now, how does it do that? It does it. The tip transmits the energy from the ultrasonic device to the irrigant. Now the irrigant will move about, making bubbles, as you can see here, bubbles. These bubbles increase in size until they are unstable. They will rupture to make an implosion. This implosion will make a lot of movement in the irrigant. You can imagine millions of bubbles being done in milliseconds. This irrigant is going to move about and clean. Also, acoustic streaming. This is moving the irrigant about in the root canal, will clean the root canal efficiently. We may use sonic vibration. This Endo activator is available with the plastic tips with different speeds. And you can see a lot of bubbles indicating a lot of movement in the irrigant fluid. And you can see here this bubbling, which indicates cleaning to the surface. It's important to understand when we use sonic, the tip moves about only in the apical region. So you're going to clean in this region mostly. But when you use the ultrasonic tip, this ultrasonic tip is going to have many curvatures. So the irrigant material will move about in the apical region and the coronal region equally. This is important because sometimes in such cases, when I've got internal resorption here and I want to clean this area, I can't do that with rotary instrumentation. I will rely on irrigation. So by ultrasonic tip and the agitation, I can clean this area, which is very difficult to clean, then obturate with thermophil, and you can see this lesion has receded. We did research, me and Dr. Lens Sha'lan, and we found we irrigated the root canals with a bevel-ended syringe, Endo activator, and the aquapic. You can see there's a very thick smear layer in this region. The Endo activator, you can see the dentinal tubules here, being opened. So the Endo activator is it's doing its job, but not efficiently. Aquapic here, we used a device that we increased the flow of the irrigant material. We irrigated, we increased the flow as much as possible. And you can see the dentinal tubules being opened. Now, I don't want to increase the flow of the irrigant as a lot. I have to use with it a side vented needle. This side vented needle is important so that irrigant does not go apically to the periapical region. It goes sideways. In another research which we have done now, and we're going to publish hopefully in the future, we saw that the hypodermic syringe, you can see the apical region, middle and coronal are filled with smear layer, thick, sorry. But when aquapic with a side vented needle, you can see signs of dentinal tubules opening. And if we combine aquapic and ultrasonics, I think the picture is very, very clear. Dentinal tubules are being opened nicely, and all this picture is without EDTA. So if we place EDTA, I think the picture would be much better. This brings me to what we call the non-instrumentation or minimum instrumentation system. There's a system called the Gentlewave now. It's very effective. It uses multi-sonic cleaning. We place the device in the pulp chamber. You don't have to place it in the pulp canal. And transmit energy, ultrasonic energy, with multi-sonic, sorry, and it will clean the canals vigorously. We may use sodium hypochlorite or EDTA. Sodium hypochlorite, then EDTA. Literature states that it is very effective, 98% effectiveness, and it removes all the organic tissue. And yet, as you can see here, the normal rotary instrumentation cleans only the canal, but the isthmus, it's untouched. This is a source of infection. But with the ultrasonics, multiple ultrasonics and the Gentlewave, you can see that all the isthmi are very, very clean. And when you obturate this area, there will be a very good environment for healing. That's why it's important when we use ultrasonics. I like to do minimum instrumentation as much as possible and rely on my ultrasonics more with sodium hypochlorite. And yet, as you can see here, I obturated with a very minimal instrumentation when I found that this canal is really very clean. This is another case whereby I've got very sclerotic canals. I opened them to, let's say, size 20, and then left the job to the ultrasonic cleaning with sodium hypochlorite and EDTA. If I remove less from the tooth structure by rotary, let's say no more than size 20 or 25, I will keep the strength of the tooth. The tooth has to be strong so that it will stand with the masticatory force. I don't remove unnecessary removal of dentine by rotary. The Endo Vac irrigation system, this is what we call the safety system. It talks about the apical negative pressure. We place the irrigant, then we place a macro cannula inside the root canal and make a negative pressure so that the irrigant enters inside the root canal. And then with the micro cannula, it sucks the liquid with its debris out. And it's a cycle whereby irrigant goes down and it gets removed by the micro cannula, and you get a very good cleaning. This is really important because it emphasizes on the apical region, so that I want lateral canals to be opened, as we can see here. This is a lateral lesion. If this lateral canal is not cleaned and obturated, I will never have healing in this region. Another small canal here. This wouldn't have been visible if I didn't do this vigorous irrigation. This is another case that came to me with a patient with a scar outside. She thought it's of a dermatological cause. When I took an X-ray, I saw this premolar, it has a lesion. So I did the instrumentation and vigorous instrumentation and irrigation with sodium hypochlorite or with ultrasonics. It turned out to be, I've got 2 canals, and with thermophil obturation, the scar is gone. So I don't need to do any, let's say, surgery to remove the scar. It's completely gone. Nowadays, laser it has entered irrigation field. We use what we call the photon-induced photoacoustic streaming. We use erbium laser with extremely low energy, and this agitates the irrigant material. And here we don't need a lot of root canal instrumentation. As you can see here, size 25, an instrument to size 25, the gauge 30 needle will enter only halfway, and the normal lasers, the tip will enter only halfway. The pips doesn't need to go in the root canal. It's only the canal will be filled with the sodium hypochlorite, and you place this tip in the pulp chamber and activate it, and you will have this activation of the irrigant fluid. Of course, we need to continuously give more irrigation to the field so that we get a fresh irrigant at this every time. The delivery devices, these are things that really are overlooked by us, but they are so important. The needles. Now, we've got many gauges. I can't really use the hypodermic syringe with a gauge 23. It's too thick. I need to use 27 or 30. At the same time, the opening is very important. This bevel is very dangerous because it extrudes irrigant epically a lot. The side vented or notched are much safer. Now, what does the needle design affect? This is a research that we're doing, me and Dr. Lenz, now. It's an ANSYS animation of the flow of the irrigant. Inside the needle, the irrigant flows with a lot of pressure. You can see it's orange type, so it's more or less here, irrigation. The more it becomes reddish, that means that the stress is more. Once the irrigant goes out from the needle, this is 3 millimeters from the apex, this is the apex here, the pressure decreases, and it decreases very much as we go to the apical region. That means if I use a side vented needle, I am safe to place my tip up to 1 millimeter from the working length. So I can increase my flow safely with the side vented needle. And we can see it here very clearly. If I increase the flow rate, and this is by a study, if I increase my flow rate with a side vented needle, the irrigant will go about 1 millimeter apically only. So I am really very safe, even if I increase my flow rate. And this is what we did with our research. And we used this Aquapic with 0.3 mil per second. And this is a lot. But with the use of the side vented, we found it is okay. The position and design, you can see if if I've got an open-ended needle, I will literally place my irrigant material in the apical region and possibly in the periapical regions. You can imagine extruding sodium hypochlorite in the periapical region. The patient will come back to you with a lot of pain and darkish color on the skin. The beveled is the same thing. The notched, well, more or less, but with the side vented, you can see the difference. That's why I emphasize that this side vented needle can go up to 1 millimeter with any flow safely. Of course, when I place my needle, I have to agitate it and make it go up and down as much as possible. Irrigate the apical region, then the middle, then coronal, and go. As you can see, as we increase the movement of the needle, there will be an increase in the pressure of in the irrigant. So the pressure will reach the apical region more, therefore more cleaning. And as we can see with this animation, with the open-ended, always the irrigant material will go out very vigorously, but it will go coronally. This is 3 millimeters from the apex. If we have a side-vented needle, we've got a vigorous lateral movement with very little apical. With the beveled, it's the same as the side-vented. A lot of irrigation will go laterally and up. That means this region, the apical region, will be filled with bacteria. And this is what we call the stagnation area. We instrument, we clean, and the debris will drop down, down, down to the apical 1 millimeter and get stagnated. So it is imperative to use side-vented needles with a good flow rate and concentrate on this region to clean it. Now, let's see some cases. I've got double deltas here. It is impossible to instrument these tiny canals, but by instrumenting the main canal and vigorous irrigation with ultrasonics and side-vented needle in this area with a good flow, you can see these canals were opened. This is a big lesion between the 4 and 5. I did ultrasonic irrigation and with the instrumentation, and after initiating a good, healthy environment, after 1 year, it has receded. After 2 years, it's gone. So just by making the environment favorable for healing, the body will do the job in healing. This is another difficult case whereby I've got total sclerosis in the lower half of the distal canal. I tried as much as possible to open it without any hope. This sclerosis was opened easily, and instrumentation, obturation was done here. I relied on the vigorous ultrasonic instrumentation after irrigation with sodium hypochlorite and ETA, removing any debris that I can find, and then I obturated. I obturated to the half, but you can see that in the periapical region, there's healing, even though it's sclerosed and unfilled. So it means that with a good irrigation and instrumentation, you make a favorable area maturation, and then after that, there will be a good healing. So the take-home message, sorry, it seems that it doesn't work. Anyway, at the end of the lecture, I urge you to enter our page of the Iraqi Endodontic Society. We've got more than 6,100 members. We share cases. I hope to share cases with you. I will be very honored to if you could see my lectures, my YouTube easy, as many. Shukran jazeelan. Oh, there's a question here about the concentration of sodium hypochlorite. I really like, as I told you, 2.5%, which is really not too toxic, and at the same time, it has all the advantages of sodium hypochlorite. Let's see if there's any other question I may. Which irrigation, Doctor, prefer for open epices? Well, open epices are really very tricky because, you know, we've got an open apex. That's why a side-vented needle is imperative. And I really try to decrease the flow rate, let's say not to 0.3, let's say 0.2, and decrease the concentration of the sodium hypochlorite, let's say to 1. Just to be on the safe side. Let's see if there's anything. I think we, sorry, if we have a tooth with a lesion, is it possible to treat it? Of course, of course. One of the colleagues is talking about a tooth with a periapical lesion. Can I treat it with just endo treatment? Well, really, endo is the first line of treatment. Episectomy is the second line. So I do my best, I do my endo treatment, and I think I showed you quite many cases of lesion healing. If they don't heal for any reason or another, we will refer to the surgery, of course. How to increase the sodium? Increasing the sodium hypochlorite temperature is a device that that's some kind of heater, or you may place it in a bath of water. Place the syringe with the sodium hypochlorite in a bath of warm water, and it will increase it. I really don't know if the Q-Mix is in the market here or not. I'm sorry. The sequence of irrigation really here, when we do irrigation or instrumentation, the first procedure is that I want a lubricant irrigant material to assist me in my instrumentation. So I always start with sodium hypochlorite. After I finish up my instrumentation here, I will irrigate again with sodium hypochlorite so that I can remove the organic tissue, and then I go to EDTA. Give it some time, let's say 1 or 2 minutes for it to act, and then wash the whole EDTA with normal saline so that I will not have any chemical in the root canal. At that time, I will, and after that, the canal will be very, it will be ready for obturation. Let's see if there's any other question. I will be very delighted to answer. Thank you very much. Talking about interaction between sodium hypochlorite and the EDTA and chlorhexidine, yeah, there is an interaction. That's why it would be beneficial to use each irrigant separately. I use the sodium hypochlorite, finish up my work, then I use the EDTA with a long, vigorous EDTA irrigation. And then if I want to use chlorhexidine, that means I don't need to use sodium hypochlorite because both of them are antibacterial. I think this question I have answered. Placed my needle in the side vented needle 1 millimeter from the apex with the moderate flow rate will do the job. Please explain. I don't know if the time is finished or Mr. Oliver, Quilla, if you can hear me.
Hello, Dr. Hussain.
Hello.
Did you finish everything, right?
Yeah, I think it wraps. Everything is wrapped up. Yeah.